Good afternoon and morning to those of you west of the Rockies. Welcome to the webinar, Opportunities and Obstacles in Rural Telehealth. Thank you for joining us. My name is Joshua Ewing and I am a Policy Associate with the National Conference of State Legislatures, covering rural health and health information technologies. I will be your moderator for the webinar today, as Giovanni said. I'd like to begin today by recognizing the Health Resources and Services Administration for funding this webinar. We could not bring you these wonderful educational opportunities without the generous support of partners like HRSA. I'd also like to thank Tom Morris and the folks over at the Federal Office of Rural Health Policy for their continued support of NCSL and our rural health activities. Now let's get down to business. We're glad to have you here today to learn about telehealth and its impact on rural healthcare. We have a wonderful program for you featuring national experts to discuss advances states have made in recent years to expand access to telehealth services in rural and frontier areas, as well as what challenges still lie ahead for policymakers who may wish to expand access to these services in their state. A quick reminder before we get started, you may ask a question at any point during the webinar. Simply type your questions into the box on the right-hand side of the screen. All questions will remain anonymous. Our first presenter today is John Blum. Mr. Blum is the John J. Waldron Research Professor of Law at the Loyola University Chicago School of Law and is a faculty member of the Beasley Institute for Health Law and Policy, as well as an adjunct professor of medical humanities at Loyola Stritch School of Medicine. Professor Blum has taught at Loyola for 21 years in the area of health law. His research spans an array of topics from domestic to international health law. He has written and spoken extensively on telemedicine issues with a particular focus on credentialing, licensure, and international e-health. Blum is a graduate of Canisius College, the University of Notre Dame Law School, and the Harvard School of Public Health. Professor Blum, the floor is now yours.
Well, thank you very much, Josh. It's a pleasure to be with you. My task today is to talk about some of the recent developments at the state level, although I'm actually going to start with some of the federal developments in the ACA, which of course it's hard to separate out federal and state activities. On my first slide, you show sort of, I'm showing a picture here of longing and a picture that has been shown for a long time in the telemedicine area about the fact that this is an area that has been on the verge of explosion ever since I've been doing this work for the past 15 or so years. But I think at this point, we really are moving very quickly. I'm not going to go over the individual elements I have on the slide about why the case is stronger every year, but suffice it to say, issues involving quality of care, utilization costs, and among a number of other things are drivers of this area. And certainly in terms of federal policy, and I'm switching now to the fourth slide, there are some key issues that are drivers and continue to be drivers for the federal government, and they're the same drivers that states have and are feeling these pressures very directly. I've highlighted three areas. One is human resources. There's been a great deal of publicity about shortages in human resources, and of course telemedicine, telehealth provides great opportunities to address these shortage problems. We also have a epidemic in chronic illness that we've read a lot about over the past few years. The bulk of our costs are in the chronic illness area, and of course that underscores the need for a considerable amount of services that may be lacking in some areas, particularly in rural areas. And then it's no surprise that if we look at demographics, we have this dramatic curve of our aging population, which is also a driver for telehealth services. So those are among, you could mention others, but these are among several that have been widely highlighted in terms of underpinning the telehealth area. Within the context of the Affordable Care Act, there are a number of areas that we could single out that have been really a focal point or focal points of development. One area that we hear a lot about is the Accountable Care Organization, which is a new delivery vehicle, but it is a delivery vehicle that in the final rule on the ACOs, telehealth was specifically mentioned as a key element to provide evidence-based medicine and engage patients. I'm sort of backing up here on the next slide. I mentioned the ACOs. There's also patient-centered medical homes, which I'll talk about in a moment. And there's a variety of reimbursement initiatives that are being implemented that have implications for all services and certainly would have implications for telehealth services, as well as a variety of innovation projects that are being developed by the Centers for Medicare and Medicaid Innovations. I mentioned ACOs. The other model of innovation that has great resonance at the state level is the patient-centered medical home. Many of the PCMH programs are programs that are being developed through state Medicaid programs. They're team-based approaches to primary care, and certainly in the context of these types of service delivery models, there is tremendous room for development and growth of telehealth services. As far as the states are concerned, and I really want to focus on states, I have a reference slide here that you could look at your leisure that comes from the American Telemedicine Association that deals with some of the state issues that are currently ongoing. I know Kristen Natoli is going to talk about some of those issues. This is a map of a couple areas that I would highlight, two of which you can see on the slide, one of which is covered up by the map, but this is an NCSL map that deals with parity legislation, which I'm going to talk about in a moment, licensure, which we're going to hear a lot more about, and the other thing that's covered is really practice standards and the evolution of practice standards, all key issues at the state level. If you're curious about, and obviously you're on the call, so you are, about getting a sense of what states are doing and what states have more extensive laws, I've highlighted 3 states in particular, California, which I believe has the most extensive and an up-to-date set of laws involving telehealth, where there's been a dramatic expansion of possibilities under California state law about telehealth. A number of the geographic boundaries that existed in others, that do exist in other states, have been overcome in the California law. Virginia is also another state to look at in terms of comprehensiveness, in terms of what they've done in reference to telehealth services. And then I put down Texas, not so much because it has comprehensive state laws, but it typifies the involvement of state medical boards. And I think it's important to be aware of the fact that whenever you're doing something in the telemedicine, telehealth area, you have to be aware of state medical board policies, and those policies hopefully are progressive and will act as a catalyst for the development of favorable regulations that will promote this area rather than frustrate it, which has been the case in some states. The one area of state law that I want to spend a bit of time talking about deals with insurance coverage and deals with mandates for private health insurance coverage. This is a map that was developed by the American Telemedicine Association that presents information on telemedicine parity laws. There has been a lot of activity in this area, and I think 2013 has probably been one of the most active years in terms of legislation dealing with parity. And simply by parity, I mean that telemedicine coverage is to be provided in state-regulated health insurance in the same way as in-person services. So it's a type of non-discrimination provision. And if you look at the map or reference the map, you can see where those laws currently exist. This is a proposed law from Florida, which has not been enacted, but was very much in play in the past legislative session, which just recently ended. And it appears that this law is going to be enacted in the next session of the Florida legislature. And you can see there's 3 areas here that it requires insurers to provide coverage for telemedicine services. It prohibits insurers from discriminating against telemedicine. and it provides Medicaid coverage among them. Those are the major details of the legislation. But this, I think, generally is typical of what we're seeing in proposed and enacted state laws. I think it's indicative of the fact that the states are aware that they want to expand coverage in this area, and not only expand coverage, but regularize the coverage through their state insurance regulations. Maryland is another state, and in the interest of time, I'm just going to mention that you should reference Maryland. They have a similar statute that allows, it's a non-discrimination provision. Vermont is yet another state that has a non-discrimination provision. So we're seeing the growth of these laws around the country. One of the final area that I want to focus on for a few moments, and I didn't mention the most obvious things in the Affordable Care Act in terms of states. I mentioned a few of the structural issues and the innovation issues. Obviously, the expansion of Medicaid is the most obvious thing that comes to mind in terms of states. There are now about, my count is correct, 20 states, including the District of Columbia, that are going with the Medicaid expansion. And of course, you know, the fact that telemedicine is already covered by many state Medicaid programs has a direct tie-in to through the Affordable Care Act. The other area, which of course is a subject of very current discussion and lots of work right now, is we rush toward the finish line to get health insurance exchanges up and running by January 1st of next year. There's a lot of activity dealing with exchanges, whether they be state, federal, or partnership exchanges. There's a lot of confusion about what qualified health plans have to offer, although states are now focusing on benchmarks that are developed in that area. And of course, an interesting question in this context deals with telehealth and whether or not the exchange plans have to cover telehealth. I mean, there are a couple of comments I want to make in concluding my remarks about that. I mean, one thing is very clear, and that is that telehealth is not an essential health benefit under law. And that has been very clearly stated by CMS. Telehealth is viewed as a type of technology as opposed to a type of service, so it's not covered under essential health benefits. I have quoted here a provision from Washington state law to that effect as well. I think the important thing, however, that doesn't mean that telehealth can't be part of a qualified health benefit plan. A state can still require a non-discrimination provision that needs to be applied to plans that are in the exchange. I think the key thing here is really an issue of are telehealth services cost effective? And if they are cost effective, it's likely that states will gravitate toward them. They may not be considered essential health benefits, but states still have some leverage to require telehealth services within the context of plans that are listed under the exchange. I'm going to turn the baton over to Dr. Richards at this point, and he will give us more detail on some of the clinical issues that are being encountered and some of the innovations. So thank you very much.
Thank you, Professor Blum. Before we turn it over to Dr. Richards, I just want to remind everyone that if you would like to ask a question of any of our speakers throughout, simply type your question into the box on the right-hand side of the screen, and please remember that all your questions will remain anonymous. Now, our next presenter is Dr. Tom Richards. Dr. Richards is the CEO of Apollo Telemedicine and Mobile Healthware. He is also a practicing physician with over 20 years of primary care medicine experience in clinics, urgent cares, and emergency rooms in 5 states. In fact, he's on loan to us from the emergency room today. He is currently consulting on 2 multi-million-dollar telehealth grants, is a frequent speaker on telehealth topics, and is on the board of directors for the Northwest Regional Telehealth Resource Center. He holds an MD and a master's degree in medical informatics from the University of Utah. Dr. Richards, the floor is now yours.
Thank you, Josh. And I'd like to thank the National Congress of State Legislators for the opportunity to present again today. And Dr. Blum did a great discussion of the legal issues around telehealth and telemedicine. I'm going to focus more on the boots on the ground perspective. I was born and raised in Wyoming, and like a lot of people in rural areas, I find that it's difficult to access specialized care in particular. there's an old Chinese curse that says, may you live in times of change. Certainly, healthcare in the United States is undergoing tremendous change, and Dr. Blum's comments about forming more of a team-based approach for healthcare, I think is going to be the model going forward, but somewhere in that team, you're going to have access to specialty care. And I think that's probably the area where telemedicine is going to be most effective and prove to be cost-effective as well. There's my slides. Okay. So you're all well familiar with the issues around healthcare right now. There's increasing demand for limited resources, and the proposed solution that we're here to talk about today is using telehealth and telemedicine for reaching some solutions. The types of telemedicine can be looked at a lot of different ways. I want today to have you focus on looking at it from a provider perspective. There's really two types of telehealth care that are used by providers. You can think of them as real-time video conferencing or synchronous telemedicine, where it's more like a telephone call. You speak, the other person speaks, everything happens in real time. This is a common model for telepsychiatry, which I'm familiar with, having worked on projects now for 4 years in telemental health, telepsychiatry. Telestroke is another good example of this. Then there's a store and forward, or what's called asynchronous model, where information is sent to a specialist and a specialist reviews it later. This is the most common form of telemedicine, actually. We've been using it for radiology for 15 or 20 years. Think of it more like a text message or an email. The information is sent, the specialist reviews it later. Now, I'm going to focus first on telemental health, and then I'll come back around and talk about an example of asynchronous telehealth using wound care, and then I'll try to pull those together at the end. The scope of the problem in mental health is significant. If you look at the nation as a whole, over 80% of the country is rural geographically. 85% of the federally designated mental health professional shortage areas are in rural areas. And there are places in this country where there literally are no psychologists, no psychiatrists, and no social workers. The rate of depression is higher in rural areas, and that creates real issues for us. This map is fairly busy, and I want to just take a couple of minutes to talk about it. I had built this map to show two things. The reddened areas show health professional shortage areas by a clinical priority score from the Rural Assistance Center. So the redder the area on the map, the greater need for our mental health services. Overlaid on that are areas that are higher population. So within that, there are metropolitan statistical areas. So if you look at the pink bordered areas, those are areas with higher population bases. The point I'm trying to make by overlaying these maps is that rural and lack of mental health services overlap significantly across this map. So who lives in these rural areas? Well, guys like this. If you look at the people who are most likely to commit suicide, the demographics would show you that Caucasian older males are the ones who most likely commit suicides. Depression is higher in rural areas. Providing mental health services is one way to address those disparities. And when we look at what it takes to actually be successful, you have to overcome three problems. Within the rural areas, there are issues around accessibility. Is there someone you can talk to when you need someone? Availability. When the patient needs one, can they actually get to one in a timely way? Many of our patients become depressed and suicidal as a result of episodic things in their lives. They lose their job, they break up with their girlfriend, they have a financial crisis. If you can get them through the moment of crisis, oftentimes you can get them into the next phase of their life and get them past that. But they need help when they need that help. And the last thing is acceptability. In rural communities, going to the mental health center is not a real acceptable option for a lot of people. There's a stigma associated with it. And for that reason, it can be a real challenge. Telemedicine actually provides a way to get around these issues. It provides accessibility any place that there's a Wi-Fi or oftentimes even a cell phone signal. It provides availability because emergency services can be made available even to rural communities from larger metropolitan areas. And it's an acceptable way to provide services because the patient can receive those services any place, at his primary care office, at the local community center, or even at home. So the question has been raised for quite a long time whether or not this actually works. This is a report of a study from last year's American Psychiatric Association meeting, and it's a really significant study, I think, because it shows that over a 4-year period with 98,000 patients, most of whom were in rural or remote clinics, the VA system found that inpatient admissions and hospitalizations were decreased by about 25%. Now, that's a really significant number for us to focus on because the cost of health care goes up exorbitantly once the patient is hospitalized. When we talk about saving money and improving care, what we really want to focus on is management of chronic disease and prevention of hospitalization. And that's true whether or not you look at congestive heart failure, COPD, diabetes, depression. All of these chronic diseases can be managed effectively using telemedicine. And if you can intervene earlier in the disease process before the patient has to be hospitalized, that's where you make the most impact, and that's where you can save the most money. Now, I wasn't able to show this video as part of my presentation, but I'm leaving you the link, and the slides will be available afterwards for you to look at. This is a HealthLink Now video, one of the companies I'm consulting on. Fair disclosure here, I'm working for this company. But they do a great job using video conferencing for telehealth. And if you want to see an example of exactly how this can work, you can tune into that YouTube video. The other opportunity I want to talk about, the second topic area, is another area I've become very interested in and worked on for a couple of years now, telewound care. Now, this is an example of store and forward technology. So think of, rather than live video conferencing now, we're talking about the model where you're sending information to a specialist who reviews it later. If you look at dermatology, radiology, wound care, anything that relies on a visual image of the patient's medical condition, whether that's follow-up from a surgery or an infection that you can see on the surface of the skin or a cancer that's topical. This is a great way to make diagnoses, follow patients, and provide expert consultation at the bedside. Now, the National Institute of Health labels skin and soft tissues wounds a major and snowballing risk to public health and the economy. That was 2 or 3 years ago. A lot of the patients that we're talking about here are in long-term care. They have chronic diseases like we've talked about. They have diabetes, they have congestive heart failure, they have spinal injuries, they have obesity. These are the common chronic conditions that lead to wounds that can be difficult to heal. Think of things like skin tears, pressure ulcers, which we used to call decubiti or bed sores, postoperative wounds after surgery that are difficult to heal because of patients' underlying chronic conditions. These are the things that are common. At any given time in our 1.5 million nursing home patients, 11% of those patients have a pressure ulcer. That amounts to an enormous number of patients, and they take a very long time to heal. Being able to identify those wounds, being able to document them and come up with a plan of care and consultation when needed is critical for treating these patients effectively. But in a patient who's in a nursing home, to get them to specialized care oftentimes means putting them in an ambulance, transporting them some distance to a specialist who then sees the patient and prescribes a round of treatment, and then the process is repeated at some future date, maybe 3 or 4 weeks later. A better way to do that, I think, is to use a cell phone, a tablet, a mobile device at the bedside. This is a website from a product that we're developing called the PUMP, the Pressure Ulcer Management Program. This is all focused on treatment for pressure ulcers or decubiti. We put together a team of experts using the wound care expert who wrote CMS's guidelines for wound care, very experienced software developers, and a really effective team. And over the last 2 years, we've developed this program for assessing wounds that can be done at the bedside. It produces a really fast, expert-guided evaluation of the wound. It allows for documentation of the changes over time so that the staff can tell more quickly if the wound is getting better or worse, because not only do the photographs show up on the system, but the system automatically graphs changes over time in size of the wound and depth of the wound, so you know if it's getting bigger or smaller. And consultation can be obtained using regular Wi-Fi or data plan systems over your mobile device. It's a way to provide care at the bedside without having to transport the patient, and a way to team build by sending information back and forth using encrypted email that's HIPAA compliant. It's, I think, a very effective way to manage wounds going forward, and it's a model of an asynchronous system that is actually much more efficient than having a video conferencing of the patient and the specialist at the bedside. Because when we look at asynchronous systems versus synchronous systems, the asynchronous systems for specialty care that's a visual system like this, a visual diagnosis, is about 3 or 4 times faster than actually bringing the specialist to the bedside using video conferencing. So we think of mental health and things like that as requiring synchronous two-way communication, but some of the research that's being done now around mental health is also being done using an asynchronous system. Dr. Peter Yellowlease in UC Davis is doing this now and is very effective, and it's much more efficient. The point I want to make is that for these systems to work, for us to be able to provide more care at a lower cost with fewer specialists for more patients on a per capita basis, which is the direction we're headed, we have to be able to find systems that are more efficient and more effective over time. And for those systems to be rolled out and to work, there has to be a reimbursement for them. And at the current time, there is really limited reimbursement for asynchronous telehealth, which limits our ability to move it forward. So I want to just focus on 2 legislative areas that I would like to see your group focus on. The first is to promote systems that reduce costs and expand access. And we would all like to see this, but actually getting it into legislation is critically important, I think, right now. And telemental health for screening and counseling is the first example. And this going forward using medical imaging for consultation, wound care, and similar applications, this asynchronous telemedicine is the second priority. And then finding a way, my last point, finding a way to use existing referral systems. In Wyoming, for instance, we refer patients to Montana, to Colorado, to Utah, to South Dakota, to all of our surrounding states. Physicians and other healthcare providers within the medical system don't pay much attention to state boundaries. What we care about is where the closest specialty care for our patient is going to be. And many times that's across a state line. If there's a way to encourage the development of interstate pacts that allow within a region or across state lines for telemedicine consultations, that would be tremendously helpful for our patients. It would save our system and our patients a lot of time and money. The concept is simply that if you have a specialist in a neighboring state and you've been traveling to see that specialist for some time, and that service can then be delivered through telehealth, and there are ways to simplify that system and make that easier. I think that's really important. It's a way, again, to provide more care to more patients at lower cost and improve the quality of that care. Now, I think Josh mentioned that I'm on loan from the emergency department, and I actually have to go back there now. So I won't be around to answer questions, but my contact information is here. If you have any questions, please feel free to contact me. Thank you.
Thank you, Dr. Richards. If you'd like to submit your questions, Dr. Richards, through the box on the right-hand side, we'll also pass those along to him following the webinar. Now, I'd like to introduce our final presenter, Kristen Natoli. Ms. Natoli serves as the Center for Telehealth and eHealth Laws Associate Director and is responsible for developing CTEL's strategic mission. She is one of 2 senior staff that provide direct legal and regulatory expert research and consultation services to CTEL's members. Ms. Natoli has extensive policy experience and knowledge in the areas of physician and nurse licensure, internet prescribing, e-consultations, Medicaid reimbursement, mHealth, and international telemedicine. As CTEL's Associate Director, she has led research efforts on these topics, which have resulted in the production of CTEL's most coveted publications, the 50-state Internet Prescribing Report, the 50-state Medicaid Reimbursement Report, the 50-state Physician Licensure Report, and the International Telemedicine Report. Ms. Natoli is also a published author and noted lecturer and speaker. Ms. Natoli, take it away.
Hello, Josh. Thank you so much for the introduction, and I'm very excited on the behalf of CTEL to be presenting at the National Conference of State Legislatures. This is something that we really look forward to talking to you all about the different laws and regulations that are impacting the area of healthcare delivery through telemedicine. For those of you that do not know CTEL, CTEL was actually established in 1995, really out of necessity by the founder, Robert J. Waters. Bob was a telemedicine expert. He was considered to be the father of telemedicine and e-health law and the founder of the modern day telemedicine movement. He wanted a place where there could be a central hub of information where people that are providing care or via telemedicine or telehealth technologies or state legislatures can come and get agnostic research information. Basically letting them know what is the climate in each state or at the federal level or even internationally in regards to telemedicine policies, laws, and regulations. And so Bob established the Center for Telehealth and e-health law. As you can see, some of our founding partners were the Mayo Clinic, Cleveland Clinic, and the list goes on. And then here's a picture of Bob. CTEL has always had a really wide and deep area of expertise in the areas of practitioner licensure, essentially privileging, e-prescribing, reimbursement, privacy issues dealing with stark and anti-kickback laws, FDA requirements, and the list goes on. And we often like to work with state legislatures, federal agencies to provide them expert information on what different states say or what the federal government states on different policies that are impacting the area of telemedicine e-health law. Today, we're just going to focus this presentation on the issues of physician licensure and the prescribing of medication through telemedicine. There are a lot of legal and regulatory issues that are impacting this field right now that in some ways are impeding the advancement of telehealth. Licensure and the prescribing of medication are just two of those. Some other ones the previous speakers touched upon are issues dealing with reimbursement and then some privacy issues as well. And so there's a lot of issues that are impacting this industry, but right now we're actually just going to focus on these two. To begin, we're going to look at the issue of licensure. A lot of times when people call CTEL, they'll say, do I need to be licensed in the state where my patient is located, or is it okay that I hold a license in, let's just say, Florida? And what we tell them is you have to be licensed where the patient is located. And I always give them the visual that if their patient is physically on the moon, they have to be licensed in that state. So that is really more of an administrative burden that is put on physicians, that they have to be licensed within the state where their patient is located. However, there are exceptions to this physician licensure rules and regulations. So before we get into that, let's talk a little bit about a general overview of what the states look like in regards to physician licensure. There's 36 states out of all 50 that require full medical licensure if you are going to provide care via telemedicine. There are 9 states that actually allow for a special telemedicine exception. And what that means is that if a physician wants to practice within a state and they want to come into that state via telemedicine technology, they can receive a very narrow license where they are allowed to just practice via telemedicine. They're not allowed to set up shop or anything like that, but the administrative burden, meaning the fees that they have to pay to the state or the exams that they have to sit through, are reduced. because they're not going to be practicing in that state in a full capacity, just through telemedicine. There are 43 states that require licensure in another locality in order to practice across state lines. And so the next, there are, like I mentioned earlier, there are licensure exceptions. The real main licensure exception is the physician-to-physician consultation. There are others, including resident training, border states, and exceptions for military personnel and VA physicians, public health service personnel, and those that are aiding in medical emergencies and national disasters. However, the exception that we see used most often, or questioned if they can use it most often, is the physician-to-physician consultation. What licensure exception allows is that if you are if you are doing any of these following activities as a physician, you may be exempt from having to maintain either a full medical license or even a special telemedicine license. We'll address the first issue, physician-to-physician consultation. A lot of times, physicians will, in the past, before telemedicine technologies even existed, would call one of their colleagues in a different state and say, I have a patient presenting with this dermatological issue. And they would describe it, they would describe the problem, and then the issue would be discussed between both physicians. And they really are colleagues. They're people, they are two medical professionals with like medical training. And so when states were creating these exceptions, specifically in the physician-to-physician consultation exception, they really were looking at a scenario that was more similar to that. Modern day use of the consultation exception by some physicians is being used or questioned by saying, well, I have a physician, there's a physician in X state that is with the patient, and they are a general practitioner, and they want to use the consultation exception for a telemedicine provider to come into their state via telemedicine technologies and talk to the patient, see the patient, and even potentially provide a treatment option for them. What the majority of states have said is that this is not really considered consultation. Once the physician coming in via telemedicine is guiding the care, there's no longer a consultation between two medical professionals. The doctor on the other end is actually taking over the care for the general practitioner or the physician that is sitting with the patient. So what physicians need to understand, and this is what we convey to them, is that licensure consultation exception really focuses on the infrequent and occasional consultation. There are actually 28 states that allow for the consultation exception. And within those states, there's only 5, and here's a sample of 3, that actually define what occasional or infrequent is. Delaware, for example, is very specific. It says that a physician can come into the state, into Delaware, coming from another state, but they can only come in providing consultation services fewer than 6 consults per year. They really want to make sure that any physician that is coming within their state is properly licensed within the state of Delaware. So if anything should happen, they could have recourse of the physician. New Mexico says no more than 10 patients per year. Wyoming says no more than 7 days in any 52-week period. So this is just, once again, the state licensing board saying you really do need to maintain a license if you're going to practice within the state. There are, like I mentioned earlier, there are 9 states that allow for a special telemedicine licensure exception, and this means that any physician that is providing care within these states does not have to sit for a full medical license. And the list is Alabama, Louisiana, Montana, Nevada, New Mexico, Ohio, Tennessee, Texas, and Wyoming. Okay, and then this is, what are the requirements for your special conditions? And they may require other conditions for a special license, and that is, one of them may be you have to maintain a full medical license in another state. There's no ethics violations and must not have an in-state office. I think we touched upon this, what is consultation versus practicing. The lines can be blurred, but it really is any time the patient is being cared for by the physician coming in over telemedicine technologies, and that telemedicine provider is really taking over the care compared to just really consulting with the physician. So what Telehealth has done, and we've done research on the issue of licensure for 20-some years. Our research is vetted. We consult with the state licensing board on this issue, and we have compiled some information that's available on our website through a really great map, and it looks at all of the licensure requirements in every state. And it's an interactive map, so you can click on it and see the states that allow for a special telemedicine license or the ones that don't. And so we encourage anybody that's interested in this topic just to go to Telehealth's website, click on the tab that says expertise, and then go to the issue of physician licensure, and you'll be able to pull up this map. So the next issue is the issue of internet prescribing. This when I began this conversation with you all, I said that there are two issues. There's the issue of licensure, and then there's the issue of telemedicine or e-prescribing. When I began, I said that licensure really is more of an administrative burden, meaning that physicians will have to either sit for an examination or pay a fee, but the information is pretty clear out there. You either have to be licensed in this state or you don't, or you can sit and receive a special telemedicine license. And the data out there is very clear. The issue of internet prescribing is a whole new beast in the area of telemedicine healthcare delivery. The reason for that is that this issue does not really appear in state laws or regulations. It's really creating a lot of confusion within the community. I'll give you an example. When Telehealth first started this research 4 years ago, we knew that there were some reports that existed out there. I got a phone call one day by a physician that said, I just read a report on so-and-so's website, and it said that you can prescribe medication via telemedicine through a telemedicine encounter without ever seeing a patient before in 32 states. And I said, oh, well, Telehealth has not done, specific research on that yet. But I'm assuming it's a credible organization, so I'm assuming the research is accurate. So not too long later, we got another call, and each time the count of what states you could provide care and a prescription via telemedicine technologies for the first time encounter was different. And so what we said internally is that 1 + 1 should always equal 2. This issue really should be this issue should always present itself in the same way. The findings of the research should always present itself in the same way. And so we decided to take on this issue. And we began our research very similar to any other law firm or research institute. We used the traditional legal and regulatory research tools, and we immediately discovered where the problem was. After we compiled all the data, we looked at the states, and there was language that said an appropriate physical examination or a face-to-face encounter, or some states just said examination. And so what happened was there was a lot, we could see very clearly that there was probably a lot of room for interpretation. Unfortunately, the interpretation that was done prior to Telehealth's report was not really on par with what the state medical board believed the statute to actually mean. And so what we did at Telehealth was we decided that if this information is going to be accurate, we're going to have to vet it with every single state medical board. So what we did was we looked at all of the states, we compiled all of the data, and we created basically a state profile for each state with a non-legalese executive summary, and then the supporting information for each state profile, so administrative regulations, state statutory requirements, and board policy statements. Once we were able to do that, we then sent each state profile to the individual states plus the territories and the District of Columbia. And what we were able to find was that almost immediately the state medical boards were coming back to us, and we worked typically with the executive directors or general counsel, and they would say, no, we didn't mean that by appropriate examination. this statute was created way before telemedicine was conceptualized. By appropriate examination, we need in-person physical touch examination. And so after the report, so we had a lot of those types of conversations, which were huge. It was a huge eye-opener, not only for CTEL, but for the community. So we put together this report, and what we determined was that there are 13 states, and you can see the states in front of you. There's California, Kansas, Maryland, New Mexico, and the list goes on, that specifically allow for a physician-patient relationship to be established through telemedicine. And so what states require before a physician could establish a relationship with a patient is that there needs to be a physical examination. And so the big overarching question is can that physical examination be established through a telemedical encounter? And the majority of states have said no. And we know that for a fact because we were able to communicate directly with them just to ask, what is your intent? These 13 states say, yes, you can have a relationship established through telemedicine. However, just because these states agree that you could establish that physician-patient relationship and conduct a physical examination through telemedicine, does not mean that all of the states are mirror images of one another when it comes to statutory requirements, administrative regulations, or board policy statements. For example, Texas, which is very specific as to what you can do or not do through telemedicine, requires that you be at an originating site. Whereas, Hawaii doesn't have that type of statement within their regulations at all. And so we see a real big difference as to what each state says specifically in regards to this issue. However, the one thing that they can all agree on is that if these encounters are to take place through telemedicine technology, the encounter has to meet or exceed the medical standard of care. So, for example, what we have heard by these states is that if you are going to have an encounter through telemedicine, and for some, let's pick a medical issue, let's say it's strep throat, and that patient is sitting at their home computer, and they dial up a doctor and they stick their tongue out into their camera, and they use Skype or GChat or Uvu or any home-based video conferencing tool. Is that physician on the other end really going to get a good read of that patient's condition? Do they really have strep throat, or do they just simply have a really bad sore throat? And is a prescription really needed? And so what a lot of states have said is, and there are certain encounters that, depending on where the patient is located, will determine if telemedicine can be used. So if a patient is sitting in their home, there's no diagnostic equipment available to actually conduct the encounter, then in that situation, telemedicine is not considered appropriate. However, if that patient instead was maybe at a hospital or clinic setting and there's a nurse or physician sitting right next to them, a nurse sitting right next to them, and they were able to do the strep throat culture, and they were able to examine the patient's throat and neck area, and then speak to the physician over telemedicine technologies and use an appropriate camera to show them the throat area, then in that situation, it may be appropriate for telemedicine to be used. So what we have seen generally, to give you an overarching general landscape, is that we see that there are 13 states that allow for a physician to establish that physician-patient relationship through a physical examination through telemedicine. In addition to that, though, there are 29 states that require a patient medical history before prescribing, in addition to the examination. There are 17 states that require a physician to establish appropriate follow-up care. That is really key because for a lot of these new corporate online-based business models, the physician may never have no prior knowledge of the patient. They may see them through this one-time encounter, and there's no follow-up care. And that's something that's a really big concern for state medical boards right now and some of the state legislatures that we've spoken to, is that how do you know that the patient really is getting good quality care if you do not follow up with them? There are 14 states that allow for an emergency prescribing exception, but it truly is an emergency, and we want to be clear on that. There are 30 states that specifically prohibit medical questionnaires and or supplied history as the sole basis for prescription. So you might see a website that says, fill in your medical history and answer these lists of questions, and our doctor or our nurse will assess your condition and will either send you a set of prescription directly to your doctor's office, will email you the prescription. I'm sorry, not your doctor's office, your pharmacy, or will email you the prescription. That is completely prohibited by 30 states. So even with this kind of general guidance and what we've been able to provide to the community, there's still a lot of questions. And this is probably the area of most confusion, and probably the area that physicians feel the most vulnerable in being potentially able to lose their medical license. And that is because, a lot of the states still don't address location requirements. Like in my previous example, we talked about, can the patient be physically located in their home and receive care for certain medical issues via telemedicine? What about, and sometimes patients or physicians, they'll call us and they'll say, what, I know I read your research report, I heard you speak at this, conference, but, and you said these certain business models were not appropriate, but according to the laws and regulations, yet these big insurance companies are partnering with other large companies, and they're providing care through these types of models. So I don't understand how this cannot be allowed. And then, the other piece is that not only when insurance companies, but large companies are endorsing these types of models, then all of a sudden the community gets a false sense of security that if my doctor is doing it, or if this large insurance company is saying, yes, you can do this, and you can receive care through this type of model, then it must be safe. And there are a lot of models that are not safe, and they're not providing good quality care to patients. And that is really a big issue of concern, especially among doctors in the rural areas. Doctors in rural parts of this country are losing patients to these types of business models that are not providing good quality health care to patients. And in a lot of cases, these types of business models are not even providing health care, period. It's not telemedicine, it's not medicine, it's just simply a verbal interaction with the doctor, and sometimes, in some cases, they decide to use video. So as a physician in a rural area, this is something that, they have expressed concern about. So when we get calls from physicians, they often ask us, what can or can I not do through a telemedical encounter through the various states. And so what we do through our research is we look at some issues. The first is, do you require a face-to-face examination? Can that examination be conducted through a two-way audio video? Can you allow that examination to be conducted through the telephone, through email, through online portal? What about on-call privileges? Can they be assumed by a physician not designated by the primary care physician? That is a model that's being used by a company right now. And what about requiring the examination to take place in an established medical site? CTEL is publishing a new report. We published our last report in regards to the issue of prescribing in 2011. We're publishing a new report, 3 new reports, one on prescribing for non-controlled substances, one on prescribing for controlled substances, and the third is pharmacists. How are they impacted by this whole scenario as well? And so what happens is that we are looking at these issues because the types of care are really impacted by where the patient is located and the requirements for physical examination. And so in 2011, when we first started to do research in this area, there were business models that did not attempt to provide care through a home-based setting, and now there are. And physicians that are being courted by these companies are asking, can I not provide care or be employed by this company? There are some healthcare attorneys that are saying, yes, I can. In-house counsel saying, yes, I can. But I really need an agnostic opinion. I need the raw data. I need somebody that could just give me the facts. And so we are really expanding this report. It will be available in the beginning of June. And any of the state legislatures or any state medical boards that are interested in looking at the laws and regulations pertaining to their particular state, please give us a call. We'd be happy to share that with you. And so, just for illustrative purposes, I wanted to show you what some of these models, look like. And this is our last two slides. Is that this is an example of a company. This is a screenshot. It says, help. For the past 2 days, I have to pee every 5 minutes, and it hurts. If you have this problem, you can receive medical care. If you have $45 and 15 minutes of time, essentially. 1, you contact us. You send us an email describing your symptoms. 2, we talk. Our doctor responds in a few minutes. You answer your detailed questions. It sounds like a UTI. 3, problem solved. Our doctor prescribes an antibiotic and a medication that alleviates the burning. We call a prescription, and 10 minutes later, you have what you need to get back on track. This company is not like your 1990s Viagra mills that are based in some foreign country. These are brick and mortar facilities that are based in the United States that are being their programs are being reimbursed by large insurance companies. They are partnering with very large Fortune 500 companies, and this is how they are providing care. This is an issue of concern for rural healthcare providers. And this is an issue of concern for people at the legislative level and also state medical boards. This, to many people, is not considered to be appropriate care. There is no physical examination. We were talking to a member from a state medical board that said, how do they know that it's a urinary tract infection if they have no previous relationship with the patient? How do they know it's not an STD or even worse, an appendicitis? A patient recently passed away of an online misdiagnosis of being diagnosed with a urinary tract infection when they actually had appendicitis. So these are the types of issues that are presenting themselves. Here's another one on, a company says, we treat bladder infections. We treat breast infections, breast pain, tenderness, warmth, chlamydia, gonorrhea, cold and allergy symptoms. I mean, looking if a woman has an issue dealing with breast pain or a lump in her breast, it seems that the most logical step would be to immediately go to a clinic or to someone that could evaluate if to make sure she does not have a more serious problem. And so these are the types of companies that are really talking to patients. They have a segment of the population's ear. And patients believe that because it's offered by physicians and it's being supported by large companies and reimbursed by large insurance companies, that it must be okay. And the doctors, the doctors are providing them high quality care in an efficient way. And in some cases, that may be accurate. In other cases, that may not be accurate. But it's important to recognize that these corporate-based models really only are a segment of the population in how they provide telemedical care. Telemedicine was started by really great academic medical facilities and teaching hospitals that were providing care that was analogous to face-to-face interaction. Just recently have we seen corporations start providing care via telemedicine with little knowledge if the care is considered to be appropriate or not. And the overall impact of this is that patients, especially the ones that are in underserved areas that are of low economic means, are going to be and have no insurance, are going to be the ones that are going to be most susceptible to this type of medical care. And in addition to that, these types of companies are running small rural healthcare providers out of business because they simply cannot compete. So these are issues that the community just needs to be aware of. There's great telemedicine, and that telemedicine is analogous to a face-to-face encounter. And then there's these other models on the opposite end of the spectrum that present care in this manner that that can be argued is really not looking for the patient's, looking after the patient's best interest. So these are, I know that we're a little bit over time, but I'd be happy to take any questions that you all have. Please feel free to call me directly or email me. I'm sorry I didn't put my email up, but it's Krista@ctel.org. And, or you can just email info@ctel.org and I'll still get it somehow. But it was a pleasure speaking with all of you today. And if you have, if you need any follow-up, we'd be happy to chat.
Thank you, Ms. Natoli, for that wonderful presentation. I'd also like to thank all of our speakers, Professor John Blum, Krista Natoli, and Dr. Tom Richards today. I am going to open the floor to a quick Q&A session. Unfortunately, we are running over a little bit, so we won't get to all of your questions. But I will try to follow up with each of you individually who I don't get to your questions. So our first question is for Professor Blum.
Yes.
Will providers be required to be licensed within the state where telehealth is received when practicing within federal healthcare exchanges?
Well, the federal exchange doesn't change the state licensing requirements. So even though the exchange is being run by the federal government, those exchanges will respect state laws. So the licensing laws are still going to be in place. That's why I think, based on what Krista's just discussed, it would really be important to revisit those state licensing laws to facilitate cross-state telehealth where appropriate.
Great. Krista, feel free to add anything you'd like to any of these. Our next question is for Krista, and it's about non-physician providers. Are the rules the same for nurses and psychologists as they are for MDs?
In regards to licensure or in regards to prescribing?
In regards to licensure.
The laws are different in regards to licensure for nurses. There's something called the Nurse Licensure Compact, and we have some research on that issue, and I'd be happy to. It's available free to the community. If you go on our website, it's contained in the free section of CTEL's library. If you need additional information, I would just have that person contact me directly.
Wonderful. Professor Blum, the next question is for you. You kind of alluded to this in your presentation, but can you elaborate a little bit on the cost savings from telehealth technologies? Specifically, are you aware of any states who have seen cost savings in their Medicaid program as a result of this technology?
Well, I can't point to studies. I know that there are studies out there that states have done, but I think the simple thing to think about in terms of cost savings is just the transportation costs alone. I mean, if you can minimize those costs, which can be considerable, not only the cost, but also, of course, the time factor. I know Dr. Richards mentioned stroke, where time is absolutely of the essence. So certainly, if you take a condition like that or other conditions where timely treatment and timely consultation is at issue, then the cost savings are going to be considerable.
Great. I think we've got time for 2 more questions. Krista, is there a model interstate telehealth bill that is being used at the moment? Are you aware of anything?
I'm not, but there's some movement within the community about that. So I could follow up with the participant.
Okay. Our final question was posed to everyone on the call. What kind of security is required for telemedicine? If using smartphones or iPads, how do we ensure patient confidentiality?
Well, telemedicine, if you're going to use smart devices, they have to be HIPAA compliant. And so, I mean, I think the thing that organizations have to think about is encryption and making sure there's appropriate encryption technology utilized in those devices. This is actually a really interesting issue, and I'll just take a second. I mean, this is the bring your own devices issue, which comes up a lot. But I think we're a lot more cognizant with all of the smart devices floating around that we have to be compliant with federal and state laws.
Well, unfortunately, I think we're out of time. this will bring a close to our webinar. Thank you again to our presenters and to all of you out there for joining us today. I want to note that this webinar has been recorded and will be made available along with the presentations on the NCSL website next week at this address. If you have additional questions following the webinar, or for those of you whose questions we unfortunately couldn't get to during, feel free to send those to the email address or call the phone number on the screen. You can also search the NCSL website. Many of the answers to your questions are available on our website at www.ncsl.org. So this now concludes our webinar, Opportunities and Obstacles in Rural Telehealth. Thank you for attending, and have a great day.